Right. Okay. What do you do here? Dr. Dakalo, hi.
It looks like he's still connecting.
Yeah, I can see that.
Let's give him another minute just to let him come on, and then he can introduce everybody.
Good afternoon, Dr. Verenga. Good afternoon, Team Ashley.
Hi, how are you?
Hello.
Oh, yes, Dr.
Hello. Hey, is that Friday? I don't know if I'll say it's a blue Friday or green Friday. It has been a roller coaster ride. Thank you so much, Sister Dumisile, for taking over. Really appreciate that. I would like to welcome you all. We are so excited to have Dr. Verenga back. We've been waiting for this for a very long time. Dr. Verenga, how are you, sir?
Great job. I'm great. Thank you so much for asking, but I'm great.
Beautiful. Yeah, I have trouble with my network here. So if you don't see me, it's okay. I'm going to just turn off my camera because I think there's a problem. But I can see you looking good. You're in your practice. How has things been?
Things are okay. We can't complain. Yeah.
Lovely. I know that today we have expanded panelists. We have Mr. Admire Zanga, who is a specialist sonographer, a subspecialist in fetal ultrasound, a lecturer in University of Zimbabwe, also working in Department of Imaging and Physics. He is also a PhD candidate studying on preeclampsia, fetal growth restriction, and obstetric Dopplers. So he's the best to be a panelist in this regard today. We also have Dr. Farai, Sydney Farai, who's an obs and gynae specialist, a subspecialist in fetal medicine, and also have a special interest in IVF. Welcome you all. Dr. Verenga, you can go ahead, sir.
Thank you so much, Dr. Dakalo. Thank you, everyone. Thank you for tuning in once again for these meetings. So, and I would also like to express my gratitude to you guys, the Pelvic Floor Foundation, the SAFEDS, and our amazing team here, the Fetal Amazing Foundation Zimbabwe team, who are working hard on the ground, and my colleagues. We have decided to join me today to be the panelists. These are colleagues I work with in the fetal medicine units here in Harare, Zimbabwe. So thank you so much. For those who are joining us for the very first time, we are covering basic ultrasound scan training courses. So we are covering it at the level of the basic course. this is not an advanced course on Dopplers, but if you do have any questions which probably may not be addressed by this presentation, you are more than welcome to ask those questions right at the end. I hope my screen is I'm sharing my screen clearly, Dr. Dakalo?
Yes, we can see the screen clearly.
All right.
And we can hear you loud and clear.
Right. So the reason why we decided to continue and probably to start with this Doppler is because so many questions arose when we did the initial presentation. Many people were asking about obstetric Dopplers. They wanted to know a little bit more. So we decided that probably it's much better to have just a dedicated section covering obstetric Dopplers so that we may answer the questions that most of the participants had during the previous sessions. So to just give you an overview, since we do have students, registrars who are joining our meetings, I've thought of probably just give you an overview of how we use Dopplers. Probably some of the indications that I'll mention are beyond this course, but we do use Dopplers for screening for conditions such as preeclampsia, fetal growth restriction, aneuploidy, and cardiac defects. And we also use for prenatal diagnosis. We use Dopplers to diagnose fetal anemia, fetal growth restriction, twin-to-twin transfusion syndrome, twin anemia polycythemia sequencing. So all these conditions we apply Doppler. We also use Dopplers for fetal surveillance, such as in fetal anemia, fetal growth restriction, and also in twin-to-twin transfusion syndrome and twin anemia polycythemia sequencing. So this is the topic we will probably cover a little bit in detail, because I think this topic is very relevant at basic level. When you are scanning patients at district level, it's a very relevant topic, fetal surveillance. So this is a topic probably we will spend much of our time discussing and trying to make it a little bit more clearer. Of course, all this which I've mentioned depends on the gestation age at which we are. So you see that between 11 to 13 weeks, we mainly do these two Dopplers, that is the uterine artery and ductus venosus Doppler. This is beyond the basic course, but I'm doing this probably to cover the students who may be in the meeting as well. So we use uterine artery Doppler and ductus venosus Dopplers to screen for preeclampsia or fetal growth restriction. And we also use ductus venosus to screen for aneuploidy. Aneuploidy, we are talking of trisomy 21, trisomy 18, and trisomy 13, and also triploidy. So there is a role when it comes to ductus venosus, especially for trisomy 21. We also use Dopplers to screen for cardiac defects, a reverse A wave in the ductus venosus in first trimester, who put the woman at high risk for cardiac defect. And this woman will need to be programmed a fetal echocardiography. Then in second trimester, we can use Doppler to screen for preeclampsia, fetal anemia, and also twin-to-twin transfusion syndrome and selective fetal growth restriction in twins. So the Dopplers that we commonly use are uterine artery Dopplers, umbilical arteries can also be used, especially in twin-to-twin transfusion syndrome. Then we use the middle cerebral artery peak systolic velocity to screen for fetal anemia and also to diagnose fetal anemia. That is in mid-gestation. Then in third trimester moving forward, the main Dopplers that we use are umbilical artery, middle cerebral artery, ductus venosus, and uterine artery Dopplers. And we use these Dopplers for fetal growth restriction diagnosis and also for fetal growth restriction surveillance. Once you've diagnosed, we want to do surveillance so that we know when to take out the baby or to push the baby a little bit further. Then we also use the Dopplers in twin-to-twin transfusion syndromes, twin anemia polycythemia sequencing diagnosis, and also surveillance. So you can see that indeed there are multiple indications for Dopplers in obstetric or in antenatal care that can be used depending on the levels at all various levels, from basic level to quaternary level. Dopplers are used in trying to to reduce morbidity and mortality in pregnancy. So, however, to make it very simple, to simplify it at the level of the basic, we are saying the role of the Dopplers is for antenatal monitoring of high-risk pregnancies with the aim of preventing perinatal death and handicap. So the Dopplers have a role in trying to see which babies are more sick, which babies need to come out, which babies need to be delivered, or which babies need to be, to be pushed a little bit or to be intervened on in the case of fetal anemia. To just recap again that in terms of Doppler, the question is, what is this Doppler? So Doppler, we are detecting the change in the perceived frequency of sound emitted by a moving source. In this case, when we are doing Doppler, the moving source we are looking at is the blood which is moving within the vessels of either the mother or the baby. Through technical means, it is now possible to determine this perceived frequency, and through the determination of this perceived frequency, it is now possible for a Doppler spectral waveform to be constructed using these differences in perceived frequency of the moving of a moving source. This was first described by Christian Doppler in 1843. I think this Doppler effect is seen in the siren of an ambulance, that as the sound sounds more high pitched as the track approaches the listener due to the compression of the wavelength, and it sounds low pitched as it passes by and continues on as the ambulance moves on. So this is the same principle was also seen with the submarines as well. Is the same principle which is used with the submarines, where they use the sound wave in their operations. This formula here defines most of the physics that we have to know about the Doppler whenever we are doing Doppler. That the size of the Doppler signal depend on a number of parameters. First of all, it depends on the velocity. So as the velocity of blood flow increases, the Doppler frequency also increases. I will show you on the pictures what we mean by that. Then the ultrasound scan frequency, the higher the ultrasound scan frequency, the higher the increased Doppler frequency. And also the choice of the frequency compromise the sensitivity to flow or penetration. Like we said when we started the basic ultrasound scan course, that the higher the frequency, the better the quality of the image, but the compromise is on the depth in terms of how far you can scan in high frequency. And the lower the frequency, unfortunately, this compromises the quality of the image you see. But it is good in terms of penetration, in terms of how far you can see with the ultrasound. The same principle applies to the Doppler, that the signal is poor when we use lower frequency, but at a depth, we might need to use lower frequency if we want to see vessels which are very deep, but the quality will be poor. Then the angle of insonation. When I was saying the angle of insonation, I'll show you on the graph on the next picture what angle of insonation is. We are saying the Doppler frequency increases as the Doppler ultrasound scan beam becomes more aligned to the flow direction. So this is what we are referring to, that when the beam is parallel to the flow, you get this nice Doppler shift, which we see there. But when the beam is now perpendicular to the floor, probably as we see here on C, where the beam is almost perpendicular to the floor of the vessel, there's very difficult Doppler shift to interpret. What we mean by Doppler shift, we're saying as the Doppler, as the blood moves in systole and in diastole, this sort of difference that we see between systole and diastole, it's easily visualized with the beam parallel to the blood flow. than when it is perpendicular. As you can see, that it's very difficult to interpret the difference between the end diastolic flow here and the peak systolic flow, which we see there. So this is what we mean by the Doppler shift. There are other parameters that we measure whenever we do Doppler, that the machine measures when you do Doppler. So the machine recognizes what you call the peak systolic velocity, which is the highest point in a Doppler spectral tracing. So this is the peak systolic velocity we see there. The peak systolic velocity in this case is reversed because it's now going down. So the machine picks this peak systolic velocity, and it also picks the end diastolic flow. The end diastolic flow is this part of the Doppler tracing, which we see before the peak systolic starts again. So this is what the machine detects. When it detects, it's going to use a formula to calculate what we call the pulsatility index and the resistive index, and also the systolic to diastolic ratio. So the systolic, the pulsatility index is calculated by this kind of a formula where we are saying the peak systolic velocity minus the diastolic and diastolic velocity divided by the mean frequency shift of the cardiac cycle as shown there. This is the pulsatility index. Then the resistive index, very simple, systolic minus diastolic over systolic. What do these indices represent? These indices are giving us the level of impedance to flow in the blood vessels. In other words, they are trying to measure the resistance to flow in the blood vessels. So they are measuring what we call downstream resistance of blood flow in terms of where that vessel is going. So if we are measuring blood which is going to the brain, we are saying how much impedance is at the level of the brain. If we are measuring blood which is going to the placenta, we are saying how much resistance is at the level of the placenta, because we are measuring the downstream resistance in that vessel. So this is what these indices are representing, the pulsatility index and the resistive index. So that is the role of the pulsatility index and the resistive index. The machine also reports on the peak systolic velocity. So the lower the resistance in blood flow, the higher the peak systolic velocity will be. The more the resistance, the less the peak systolic velocity will be. So we also use this in terms of fetal anemia, because if the blood is thin, in most cases it will move at a faster speed than when it is thick with a lot of red blood vessels. So let's go to the uterinatal Doppler technique once again. There are two ways in which uterinatal Doppler can be done. We have the transabdominal route and the transvaginal route. For the sake of the basic course, probably I will focus more on the transabdominal route, because I think most people will have access to the transvaginal probe. But the transvaginal route, normally the urinary bladder can be emptied or just partially filled. We don't need a full bladder, and we need to get the urinary as it goes up the uterus at the level of the isthmus, the isthmic portion of the uterus. This is where we should assemble it. When we are saying angle of insonation, you can see this is the pulse wave gate there, the pulse wave line. So the pulse wave line should be in the same angle as the vessel. As you can see here, that the angle was 0. So the angle was 0. This is what we mean when you are saying, if you want a very good Doppler tracing, which you can assess, make sure that your angle of insonation is as 0 as possible. This can be achieved by either dipping the probe or finding a vessel which is nicely aligning to the pulse wave gate. So that is uterinatal day we are sampling, and this is the tracing. This is the pulsatility index, and this is the resistive index, which are all measuring the impedance or the resistance in the vessel which you are sampling. Then we have the uterinatal pulsatility peak systolic there. The velocity should be 60. In this case, you can see it was just on the borderline there. Probably if we had just slightly corrected the angle to align, it could have been 60. or if you take it a little bit higher, it could be that you are taking the branches of the uterine artery. Then in terms of the transabdominal approach, we illustrated when we were doing the basic course that you want to take the uterine artery where the vessels cross the iliac vessels, where the uterine artery crosses the iliac vessel, that is the point which you want to take the uterine artery. So the pulse wave gate should be 2 millimeters. This pulse wave gate can be adjusted so that it is 2 millimeters when you are assembling, and the angle of installation should be less than 30 degrees. Even when you correct for the angle, make sure that your angle does not exceed 30 degrees. Umbilical artery Doppler, once again, you should make sure that your pulse wave gate is parallel to the vessel as much as shown here, where the angle was 0 degrees, and the pulse wave gate should be 2 millimeters. The pulse wave gate there. When you correct your Dopplers, especially when you lower a little bit the Doppler gain and increase the what you call the wall motion filter, you'll be able to distinguish the two umbilical arteries, and you want to sample in the center of the umbilical arteries. If you do sampling at the periphery, you may not get a clear tracing of the Doppler spectral waveform, because the blood in the vessel moves at maximum speed in the middle of the vessel than it is at the periphery, where there's tagging of blood that happens at the peripheries. So try to go to the middle of the vessel where blood is moving at maximal speed, and you sample there and you get a nice Doppler tracing. Again, when we are interpreting the umbilical artery, we are saying this is peak systolic and this is end diastolic. Umbilical artery in normal pregnancies should be a low impedance flow. As a result, we should have a lot of flow in end diastole as shown in this image. So in end diastole, we should have a lot of flow. This therefore follows that our pulsatility index and our resistive index should be low. So as you can see, it was 0.9 for pulsatility index and about 0.6 something for resistive index. Don't tell me, is this normal? You can only know that it's normal if you check the nomogram. You should check the nomogram to see if your measurement is still normal or not. But by eyeballing with the experience, you can eyeball and say, look, this is a very good flow in end diastole as is shown there. Just before I proceed, the uterine artery in a normal formed, in normal pregnancy, where the placenta is normally formed and is functioning well, we do not expect to see notching in third trimester. This is notching where we are seeing systolic there. Then there's a dip before the diastole continues, and we have a low end diastolic flow there in the uterine artery. This just shows that there's a lot of impedance at the level of the uterine, which normally sort of points to a placenta which is not perfusing well, where we are saying there's a lot of resistance at the level of the placenta. So this is not normal to see both in second trimester and also in third trimester. But in first trimester, this may be just normal, because this is what we expect to see more so in early pregnancy and outside pregnancy, where there's a lot of impedance to flow in the uterine arteries. The midcerebral artery, like we say that we sample the midcerebral artery at the level of the circle of Willis. When we identify the circle of Willis at the base of the skull, we will see vessels which are going up on the wings of the sphenoid bone, and these are the midcerebral arteries, and we want to sample it just on its second sort of second segment as it goes all the way to the skull there. So this is where we want to sample it. In uterus, in normal pregnancy, blood flow in the midcerebral artery is normally high impedance or high resistance. This is normal in uterus. So a baby who is doing well will show us a high resistance flow in the midcerebral artery, as you can see here by the peak systolic, which is a 1.69, and resistive index of 0.8. Of course, you have to check the nomogram to see if it is within normal, but this one was normal. You can see that there's reduced end diastolic flow when you compare to the systolic we see there. So this is what we expect in the mid-cerebral artery, and try to make sure that the angle is as close to zero as possible when you are sampling the mid-cerebral artery, because the peak systolic velocity has a role in screening for fetal anemia, and it is affected by the angle. So if your angle is not good, you may underestimate the peak systolic velocity in that mid-cerebral artery. Right, so to just proceed again, just to show you the difference that you may experience when you sample. This is a normal mid-cerebral artery, but this is not a normal mid-cerebral artery. How is it normal? Because we said the mid-cerebral artery normally is a high resistance flow, while in normal cases, but in abnormal cases where the baby is complaining and is saying, I'm not getting enough oxygen, the baby is going to vasodilate in the mid-cerebral artery vessels, and there is going to be increased blood flow during end diastole, as you can see there. So in other words, the mid-cerebral artery Doppler will begin to mirror the umbilical artery Doppler, as you can see there. This is a mid-cerebral artery which is now mirroring umbilical artery Doppler, because this baby is not getting enough oxygen, so it's shunting, it's now redistributing blood to the mid-cerebral artery, and you can see there's a lot of flow in the end diastole compared to the other one which you see, which is normal there. So that's mid-cerebral artery Doppler. These are more pictures of the mid-cerebral artery again, to just emphasize the points here, that this is where you want to sample, and this is normal mid-cerebral artery Doppler there. Very nice demonstration of the mid-cerebral artery Doppler. Then the ductus venosus. The ductus venosus is a very difficult vessel to sample for most people when they start to scan. But like we described the last time, that the ductus venosus is a continuation of the umbilical vein. That is the small vessel that continues as the umbilical vein, and it goes all the way to empty into an appendage which is on the right atrium of the heart. Of course, books will teach you and say it empties directly in the inferior vena cava. Yes, they meet somewhere there in the appendage with the inferior vena cava, and they empty directly into the right side of the heart. The ductus venosus, we can identify it easily when you put on color, because it will alias. When we are saying aliasing, we mean there is a mix of colors that we see. Instead of seeing the usual blue and red, we're going to see an orange color. We see this orange color whenever there is turbulence in flow, whenever there's sort of a lot of resistance to blood flow, there is what we call turbulence. So because it is a cone-shaped vessel, which makes it difficult for blood to pass through, so there is going to be turbulence or orange color, and this is how we identify it. And when we sample it, what do we expect to see? We expect to see a systolic component and a diastolic component and an A-wave component. An A-wave component represents arterial systole. The right side of the heart, the right atrium, when it contracts, it gives us this kind of a waveform. So the role of the systolic, of the ductus venosus, it sort of gives us information about the right side of the heart. It tells us whether the right side of the heart is under strain or not. If the right side of the heart is under strain, we are going to see a reduction in flow within the A wave there. We're going to see a reduction in flow with the A wave, so that with increased strain of the right side of the heart, we may end up with even reversal in the A wave. The pulsatility index of the vein will also go higher when we have a lot of a strain which is happening to the right side of the heart. We'll see an increase in the pulsatility index of the vein here, which is the PIV, which we see there. It will continue to go up in abnormal cases. I'll show you some abnormal cases just now. But when you are doing the ductus venosus, we need to make sure that our gate is covered in the whole vessel, but in first trimester, it should always be less than 1 millimeters for the sake of the students. But in second trimester, just make sure that your pulse wave gate is covered in the whole vessel, which you are assembling in ductus venosus Doppler. Right, so probably I've gone through all this. I'll move on, and I've also gone through this and explained everything. Then let's go to fetal surveillance, which we said is one of the most important use of fetal Dopplers, which some of you will probably be using as you scan babies. Some of you may say, who should be put under surveillance? Like we said during the growth assessment lecture, all babies who are below the 10 centals, we classify them as babies who are not growing within normal range, and they are called small for gestational age babies. So all small for gestational age babies should be interrogated to find out whether they are small because they are abnormal small, or they are small because they are constantly small, to find out if they are small because they are experiencing placenta insufficiency. So when you are doing Dopplers, we want to try and distinguish small for gestational age babies and see which kind of smallness these babies have. So we do fetal Dopplers to try and interrogate these babies. And we also want to distinguish the early onset and the late onset depending on the gestational age that these babies are currently are. So when you are able to do surveillance, we will make an impact in terms of the both maternal and perinatal, both mortality and morbidity, perinatal morbidity and mortality, and we will reduce by a factor of 5 perinatal morbidity and 4 to 5 perinatal morbidity and mortality if we are able to put babies under surveillance with timely delivery. And this is the study that shows that when we do monitoring, we are able to reduce both perinatal morbidity and mortality by a factor of 4 to 5. So when we are monitoring, sorry, my device is ticking up a little bit. I hope it's not happening to you guys there. So so when we are monitoring, the most important surveillance tool that we want to do is the umbilical artery, the middle cerebral artery, and the ductus venosus. And of course, we may want to use the uterine artery to diagnose some evidence of placenta insufficiency. Then, and the goals of us to monitor is to assess the risk and the extent of the hypoxia or the acidosis that the baby is going through, and to also assess the risk of stillbirth and assess the rate of clinical deterioration. This is so evident in cases of preeclampsia. I know in our region there are lots of preeclampsia cases, and these cases would definitely benefit from surveillance. And we also want to plan the appropriate interval for the next visit in terms of the surveillance, and to decide on the timing of delivery. The timing of delivery is very important. Most babies, they do not do well because they are being delivered at the wrong time. But if all our babies can be scanned in the right way, we can make sure that babies are delivered at the right time. They don't come out too late, and they don't stay too long inside the uterus through fetal surveillance. Then for the babies who are very early, the early onset, that before 32 weeks, how then do we use Doppler to monitor these babies? Because these babies, if we don't monitor them, they are more likely to die inside. But for you to understand why we have to monitor these babies the way we have to understand the pathology that is very, very common with early onset fetal growth restriction. And this pathology, in the early onset cases, we have what we call a perfusion disorder, which is happening at the level of the placenta microvasculature, especially the level of the villi. The villi are clogged, the villi are not perfusing nicely. As a result, we see a typical deterioration that occurs in the Dopplers. So we see a deterioration in the umbilical artery Dopplers, a deterioration in the MCA, a deterioration in the ductus venosus before subsequent fetal demise. So what is it that we see? This is an image from a paper by Professor Bashat. What do we normally see in babies who are deteriorating secondary to early onset fetal growth restriction due to placenta insufficiency? So the early changes that we see, we are going to see that the umbilical artery Doppler is going to change from the normal flows which I was seeing you, and we are going to see a decreased flow in end diastole as shown there. This may take between 2 to 6 weeks to experience this. Then the late changes that we will see in the umbilical artery is the absent end diastolic flow and the subsequent reverse end diastolic flow. We see there. These are sort of the rough time frames that the babies have to go through to show us these changes. What is important is to note that for us to move from a normal umbilical artery Doppler to a situation where we have an absent end diastolic flow, it may take a period of 6 weeks or more. So this therefore follows that if we see a baby who demises in uterus, it simply shows that we have an ineffective system of fetal surveillance or fetal monitoring, so that we have totally failed to pick this baby for a period of more than a month, that there's a baby who is not doing well. So in other words, the message is that babies do not just wake up having deteriorated from a normal umbilical artery Doppler. Suddenly the baby is dying inside the uterus. It doesn't work that way. So because of this, babies who are not doing well, give us time to identify them and to make an appropriate intervention. Because if we look at the time frame that it may take for a baby to just deteriorate from a normal Doppler to demising, roughly a baby will take 5 weeks shortest, and longest a baby may take even 11 weeks. So in other words, I was saying from a normal Doppler to the demise of a baby may take roughly between a month to almost, at most, probably a month and 3 weeks. So that is a very long time for us to be able to identify a sick baby and do something about it. So this is why it is very important for all pregnant women to be scanned, so that small babies are identified and they are put under surveillance, because it is these babies who are likely to die in uterus. Then in terms of the middle cerebral artery, the middle cerebral artery also goes abnormal in early onset cases. We'll see what we call brain sparing, which I've already showed you, that there is increased flow in end diastole before we met with fetal demise. But there is a vessel which is so important in monitoring early onset cases, which is the ductus venosus. So the ductus venosus will start as a normal ductus venosus with a normal airwave. As the baby continues to deteriorate, we will see that there's going to be a reduction in the airwave. Then we see an absent airwave. Then we see a reverse airwave. You can imagine that still the baby is not yet dying, is not yet dead by the time we get there. Then if we don't do anything about this, eventually the baby will die in the next 2 to 3 days. So what is the message? The message is that with proper monitoring of the fetal Dopplers, it is possible to prevent intrauterine fetal demise. This is so common in our regions with preeclampsia, where we see a lot of intrauterine fetal demise because babies are not being monitored properly the way they are supposed to be monitored. Then we can also use, of course, the gross monitoring, where we ask the mother if they are perceiving fetal movements. But what we learn with biophysical profiles, as far as the fetal activity is concerned, that it will take, it may stretch throughout all this range of monitoring, where the woman may come and say, I'm not perceiving fetal movements. You do Dopplers. Dopplers may be normal or within the period of surveillance, and you may want to continue. But the message is that babies do not just die. There are a number of parameters that you can use that may also include a CTG to use to monitor babies who are at the risk of demise. That is early onset. Then for late onset fetal growth restriction, this is also common in our region because of preeclampsia, late onset preeclampsia disease. But most of the cases of late onset, it's not a perfusion disorder. It's more of a villus diffusion disorder, where we are saying there is a problem of diffusion of nutrients across the uterine-placenta interface. So because of that, we may not see the typical changes in Dopplers that we normally see in early onset disease, where it is a perfusion disorder. So that means that pattern which I showed you there may not follow as far as the late onset disease is concerned, because there's not much pressure, sort of resistance to flow which is happening at the level of the placenta. It's more of the inability of the nutrient to diffuse, because the utero-placenta interface is more of netted, and there's a lot of calcification happening at that level. So as a result, the umbilical artery Doppler may still be normal in these cases, or there may be just a slight derangement like a high PI in those who are above 32 weeks. But what these babies will complain of is a change in the middle cerebral artery. So these babies are going to show us brain sparing. This is where the application of what you call the cerebral placenta ratio becomes very important, where we have to compare the PI in the middle cerebral artery to that in the umbilical artery to see if it is abnormal. Normally, it should always be more than 1 in normal cases, but if it is now inverted, where it is now less than 1, then you need to worry for these babies that they may demise inside the uterus. This is an entity which is very difficult to diagnose, because in most cases, most centers don't do middle cerebral artery Doppler. They do the umbilical artery Doppler. So the umbilical artery Doppler will be normal. These are the babies who demise with a normal umbilical artery Doppler, but they demise because it's not a perfusion disorder, it's a diffusion disorder. But if you were to check the middle cerebral artery, you'll see that the baby is already complaining of lack of oxygen with lots of blood flow to the brain. And these babies may demise if they are left unattended. So that's late onset fetal growth restriction after 32 is the application of fetal Dopplers. So this is why it is important not to do middle cerebral artery Doppler alone for small babies after 32 weeks. Because if you rely on umbilical artery Doppler, for sure you're going to miss a lot of late onset babies, fetal growth restriction babies. This is so important to take note of, because in our region, we have lots of preeclampsias, lots of late onset disease, and sometimes lots of late onset fetal growth restriction in environments where only umbilical artery Doppler is going to be done, is going to be deceiving. Then in terms, we also use these Dopplers to determine delivery. In terms of decision to delivery, after 32 weeks, we normally say when the umbilical artery Doppler PI is above the 95th centile, or a middle cerebral artery PI is less than the 5th centile at 37 weeks or after, we normally recommend delivery, because this is what most guidelines will recommend as well, and this is what we recommend in our unit. So, however, if we have an absent or reverse end diastolic flow after 32 weeks, we recommend delivery straight away without thinking. This is just a case of a high umbilical artery PI at term there. 1.23 at term is abnormal if you check the nomogram. So this was reduced end diastolic flow, a high PI. Then this is a case of absent end diastolic flow. There is no flow at all. This is a very sick baby who is no longer getting enough oxygen. There's a lot of resistance at the level of the placenta. If you look, the pulsatility index is now 2.41. The resistive index is now 1.0. Because of its formula, it will always stay at 1. So this is an abnormal baby here, a baby who is so sick and who need to be taken out. Then this is the middle cerebral artery, which is showing increased end diastolic flow, redistribution in the middle cerebral artery, and the pulsatility index is 1 there. Then in our unit, for fetal growth restricted babies with a normal Doppler, we normally recommend that they be delivered between 38 to 39 weeks. If the Doppler is abnormal, we don't recommend that they continue to go on and on because of the risk that they may have intrauterine fetal demise or suffer from hypoxic injury. So once they are 38 to 39 weeks, we recommend delivery. Then whenever we recommend delivery, we always recommend for the abnormal Doppler that it occurs within 24 hours, but sometimes it depends. Sometimes depending on what we have seen on the scan, we can say 24 to 48 hours. Then in terms of, I've said quite a number of things about Dopplers. Now I just want to test the understanding. I've just put this random, some of our random images. It's more of a post-test of some sort, which I want to ask you guys, and I want you to answer me as I do that. This is a Doppler. I'll tell you what it is. This is a ductus venosus Doppler. What do you think about these two ductus venosus Dopplers? Are they normal ductus venosus Dopplers, which we are looking at in this case? I'll just give you a few seconds to just go through the images, then I'll describe what these images look, what they mean. So this is indeed a ductus venosus Doppler, but this ductus venosus Doppler is not normal. You can see that there's a dipping in the A wave there. There's a dipping. This is a baby who was very sick. You can see there's even ascites already accumulating there. So this is a baby who was very sick, and there was now a reduced A wave, and the PI in the ductus venosus was very high at 0.76. The second picture again, we are seeing a ductus venosus with a very much reduced A wave, almost close to being absent there. So this is a reduced A wave. This is a baby who again is not doing well, where the heart is already complaining and failing to cope with the downstream resistance. So the right side of the heart is almost giving up here. So there is absent, close to absent A wave. There's just very much reduced A wave, and you can see that the PI is very high at 1.16. So of course, you need to see on a nomogram, but this was a very high pulsatility index of the vein of 1.18, and this PI as well was very high at 1.17. Again, to illustrate again, another ductus venosus there. You can see that there is so much reduced A wave in the ductus venosus, which again shows that this baby was not doing great, and the baby was, the heart was complaining due to the increased pressure of the circulation. Umbilical artery, tell me what you see on these two umbilical arteries, then I'll go through them. So those are two umbilical arteries. So here we are looking at umbilical artery. We can see that there is so much reduced end diastolic flow here. So there is reduced end diastolic flow, and the pulsatility index is very high, 1.53 pulsatility index, and the receiving index 0.76. I know that there are many centers which just rely on the resistive index. Like we said, that for screening purposes, resistive index is a very good parameter. But for a specialist center such as a fetal medicine, the pulsatility index will have more value because it will continue to show you the deterioration or the worsening of the condition. Because the moment you have absent end diastolic flow, in most cases, the resistive index will always remain at 1 because of the formula which we use to calculate the resistive index. But the pulsatility index will always continue to show you the ever-increasing deterioration in the umbilical artery. So this is an umbilical artery with a high pulsatility index, which shows that there is a lot of resistance at the level of the placenta. Just a quick recap, the umbilical artery is measuring blood flow towards the placenta. So there is a lot of resistance. Then when you come to this one, we can see that there is now a...
Dr. Verenga.
Yes.
Just to be sure, or unless maybe you are you saying it's reduced or increased?
So
in
reduced.
This one, in the first one.
reduced end diastolic flow, sorry. This is the reduced end diastolic flow in the umbilical artery when you compare to the normal ones, which I showed you.
Mm-hmm.
So this is so much reduced. It's reduced here because the pulsatility index, that's the pulsatility index there. The normal one, let me just take you to the normal one so that we can correlate well. Probably, I think I have the normal one just after here. This is the normal one. Look at the normal one, how it looks. So that's the normal umbilical artery here. So this is a reduced end diastolic, end diastolic flow with a high PI. When you see the umbilical artery looking like a sawtooth kind of appearance, certainly this is not a normal umbilical artery. If you do the measurements and you look at this pulsatility index, it will certainly be above the 95th or the 90th centile, depending on the nomograms you are using. So this is the reduced end diastolic flow. It's not absent, but it is reduced. Then when you come to this one, there is an...
And this the RI of 0.76 I see there. So if I was doing it, I was just going to look at that RI and resistance index, which is less than 1. Tell me in that regard, how would you then interpret it based on that?
Thank you so much, Dr. Dakalo, for raising that. Let me clarify that point. When I was a registrar, I was also taught from the same book that as long as the resistive index is less than 1, I want you to be aware that resistive index cannot be more than 1 because of the formula of calculating the resistive index. No matter how bad things are, let me just take you to one of the images here. I think I showed it when I was presenting. Look at this umbilical artery. There is absent end diastolic flow. Look where the resistive index is. It is 1. But look at this pulsatility index there, which is 2.41. So the resistive index, its maximum value is 1. But there is a what you call the 95th centile of the resistive index, which you have to check on the nomogram. This value on the nomogram will be abnormal for the gestational age of this patient at 35 weeks. Are you getting that? The 50th centile at 35 weeks of the umbilical artery probably should be around 0.56 there or 0.5 something. So 0.76 at 35 weeks is not a normal resistive index. I don't know if you are getting it. It's the same scenario with the nuchal, the explanation with the nuchal, that we do not use arbitrary values. We plot the value on the nomogram. You check your nomogram, make sure it is normal, because at 35 weeks, this 0.76 will not be within normal range. So it will be a high resistive index.
I get you. You know, that's why we need the Verenga Fridays. Thank you so much for the clarity. Go ahead.
Thank you, Doctor. I hope I've clarified to most people, because that was the teaching I also got when I was a registrar in obstetrics and gynecology, but thanks to fetal medicine. Right, so let's go to this one. This one, when you look at it, you can see that there is peak systolic flow. Then when you come to the end, there is something which is coming down here. So this represents the reverse end diastolic flow. We have a reversal which is now happening right at the end of diastole, which again shows a much higher level of resistance, which is happening at the level of the umbilical artery. And if you look at the PI, it's so much higher. The PI 3.26 is the PI. So this is worsening umbilical artery Doppler, which shows that the baby is in trouble. The baby is laboring so much to feed itself, so that at some point, blood is actually flowing backwards towards the baby instead of going to the placenta to get the nutrients. This is what it means. Then I've put again the two images. Again, there are two images of the umbilical artery. I want you to look at them and think what you are thinking. Then I'll explain them again. Let me just check our time. Oh, our time is almost there. The two images again. So this again, look, this is systolic flow. Now, diastolic flow, the wall of diastolic flow is almost reversed now. It's all reversed here. So the wall diastolic flow is reversed. Look at the resistive index, at the pulsatility index, 3.95. This is a baby who is now very sick, lacking oxygen, complaining that the placenta is almost dead because blood is literally flowing back because of the resistance that is happening at the level of the placenta. This is a normal, just for comparison's sake, that this is normal. A well-perfused placenta, which is allowing blood to flow in the normal way, is looking like this. This is just reduced, very much reduced to absent and diastolic flow. Sometimes you see this kind of intermittent where there's absent to reduce or absent to reverse flow. All these are patterns of abnormalities that you will see when you are assembling the umbilical arteries. So here it's slightly, it's reduced here, but here it's absent, reduce, absent, reduce, absent. This intermittent change, we normally see this in monochorionic diamnotic, like we were saying the other day. That is actually the worst stage of garatical staging of FGR in selective fetal growth restriction babies. Right, so this is abnormal. Then we come again, here it's totally absent. This is absent and diastolic flow we see there, right? Then when you come to the uterine arteries, so we can see from these uterine arteries that there is notching. I think I've already demonstrated this notch, that it also speaks to the placenta, that this placenta is a lot of resistance. This was a 31 weeker. So you can see at the 31 weeks, the placenta was still showing a lot of resistance, which points us that this placenta, we may not be able to feed the baby because it's screening positive for placenta insufficiency. So this notching is not normal to see more so in third trimester at the level of the uterine arteries. We use it when you want to come up with the reason why babies are small, whether it is placenta insufficiency, fetal infection, or there are chromosome abnormalities. Because in placenta insufficiency, we are going to see evidence of placenta insufficiency as is shown here in the uterine arteries. These are normal uterine arteries, so that we have a comparison. This is normal. This is probably just a raised PI, but this is a very normal uterine artery there at 37 weeks there. So that's a normal uterine artery. You can see it's almost mimicking the umbilical artery. The placenta is well perfused. If you compare it with this one, which is poorly perfused, where there's notching and so much reduced flow in end diastole. To just explain this again, that in terms of predicting fetal acidosis, it is not one parameter that may help us to predict fetal acidosis, but there are certain parameters that we know that when they are abnormal, the likelihood of fetal acidosis increases. And these parameters we include abnormal ductus venosus, absent movement or absent fetal tone when you are scanning babies, and also if you are able to do CTG where there is persistent bradycardia CTG or a short-term variation of less than 3.5 millisecond. So these parameters sort of predict if the baby is likely to be in hypoxia compared to the other parameters. This is why when the other parameters are abnormal, we still need other parameters to continue to monitor the baby to see if the likelihood of fetal acidosis is there, so that we can intervene. So we will not just intervene based on the one parameter. This is why multi-parameter assessment is very important when you want to make a decision to deliver. To just summarize fetal surveillance, to say when a baby is suspected to be FGR, we want to do the Dopplers, all the Dopplers, and if the Dopplers are normal initially, they have to come back every 2 weeks where we assess all the Dopplers. For early onset, umbilical artery Doppler is very important because it's rare for the umbilical artery Doppler to be normal, while the others are abnormal in early onset disease. But in late onset disease, always watch for the middle cerebral artery as well. Then if the umbilical artery Doppler is normal, like I said, for small babies, we recommend that they be delivered between 30 to 39 weeks. And I think most of the international guidelines agree with us on this one. Some say 39 to 40, but we say 38 to 39 weeks in our setting. Then when the umbilical Doppler is abnormal, if the baby is before 37 weeks, after 37 weeks, we recommend delivery for an abnormal umbilical, because we are saying there's no need to continue to expose the risk to the baby to the risk of hypoxia and acidosis. But if it is before that, we try to monitor the baby, and after 32 weeks, if it is absent end-diastolic flow in the umbilical Doppler, we deliver after antenatal steroids. Then before 32 weeks, we use the ductus venosus to determine which babies are going to come out. The reason why we are very strict for before 32 weeks is that our neonatal unit does not have enough ventilators to ventilate babies before they are 1,000 grams. So we try to push our babies to go above 1,000 grams before we recommend that they be delivered, so that they have a chance in life, so that if they cannot breathe on their own, they can be ventilated. Thank you so much for your attention. I think I'll leave the room for questions. Thank you so much, Dr. Dakalo. I think I'll give back the time to you.
Yes, Dr. Verenga, thank you so much. That was very lovely, and it was very informative. Dr. Verenga, please go back to the normal Doppler picture. Because at this this kind of talks are meant for also our nursing junior doctors, interns, and everyone. So on the normal Doppler, please show me the peak the systolic and also the end diastolic by just pointing at it.
This is the peak.
Which peak systolic, that one?
End diastolic.
Okay. End diastolic
Peak
is there.
systolic, end diastolic.
Okay.
The machine will also show you in terms of the values. These are the values there. But always make sure, if you are going to do auto tracing, make sure that the artificial intelligence of the machine is detected the right end diastolic. Because some machines, artificial intelligence, may pick up the wrong side. So this is what the machine is telling me that it has picked. Those small arrows is what the machine is showing me that it is identified as the peak systolic there. And the end diastolic, those blue arrows are what the machine is telling me that it has managed to identify. And the machine is averaged these four and also average these four to give me that value and that value there. And the machine will have used these values to calculate the PI and the RI. So if your machine picks up the wrong, because some machines are not very sensitive, or if your Doppler spectrum is not nice or not very good, or is not well traced, the machine will fail to identify it and will measure wrongly. And in that case, you may need to do it manually.
So that was another question. That was another question. That what do you now suggest? Do we do an auto calculation if you have, maybe you don't have a perfect perfect picture like Dr. Verenga's picture? You find that you've got good waves, 3 or 4 waves, but the other 5 or 6 are not normal. What do you suggest on when we measure?
Right. So I want to give you a classical example of a poorly traced one. Look at this one carefully, right? If you look at this one, this part where there is an arrow there, it is possible that the machine could have summarized this into the calculation. So the trick is, when you are doing it, if you have to look at those arrows, if your machine shows you these arrows, if indeed the arrows are on the correct position, you don't have to worry. But if the arrows are not on the correct position, then you have to do it manually. So you have to manually trace the waveform as you said, so that the machine can measure properly. But if your measurements are good, then you can allow auto tracing, but always check and make sure that the machine is managed, the artificial intelligence of the machine is managed to trace your waveform nicely.
All right. Dr. Verenga, as always, you've got so many questions here. There's a question from Anonymous saying that, Dr. Verenga, is it mandatory to do fetal Doppler whenever one is doing obstetric ultrasound?
Not at all. Remember, we classified when we said who should be done Dopplers from the beginning. We said, even from the very first lecture, we said fetal Dopplers are for babies who are small for gestational age. Remember, we said they are small. If a baby is small for gestational age, we need to interrogate that baby and find out why is the baby small. Because we explained that there are 3 to 4 type causes of smallness. Babies can be small because they are constitutionally small. So these babies are going to pass because they are going to have a normal Doppler, they are going to have a normal fetal anatomy, and they are not going to have any stigmata of fetal infection. Then number 2, babies can be small because they have a fetal infection. These babies are going to probably to have maybe a normal Doppler, but they will have some features of infection like calcification in the liver, calcification in the brain, and so forth, and an abnormal or a placentomegaly. Then we'll have these other babies who are small because the placenta is failing. These are the babies that will give you an abnormal Doppler. So a baby who is not growing as it should, when you do your Doppler, or when you do your biometry and you put on the nomogram and you see that baby is smaller than what it should be, that baby should be subjected to fetal Dopplers. But a normally growing baby, it's not necessary to do that. But when people come to fetal medicine units, you see that we do it on every patient because we're a training center. We want all our staff to be masters in doing Dopplers, hence they do it on everyone.
Yes, Mr. Zanga, I hope you can hear me. So there is a question here from Ziki. Ziki is from Zimbabwe. Ziki is saying, what is the sensitivity of Doppler in predicting fetal outcome? Dr. Zanga, Mr. Zanga, would you be able to answer that? And Dr. Farai, if you want to attempt that as well. Otherwise, we can go to Dr. Verenga. Can go ahead.
Hello.
Yes, Mr. Zanga, and welcome.
Can
and thank you for
me?
joining us. We can hear you so well. Thank you for joining us.
You're welcome. What was?
Go ahead, Mr. Zanga.
Can you repeat the question?
Oh, the question was...
I'm waiting for the recap of the question.
No problem, Mr. Zanga. The question is from Dr. Ziki. Is saying, what is the sensitivity of the Doppler in predicting fetal outcome?
Okay, so from the presentation, I think you can establish that Dopplers are quite vital in predicting the decision to deliver. That's our main reason, to establish the state of the fetus in as far as, is it safe for us to keep the baby inside, or it's better to give them a fighting chance outside. So depending on the gestational age and on the type of where we detect the abnormality of the Dopplers, we will then decide to do surveillance using set protocol, like what he was saying, that if it is before 32 weeks, we are using the ductus venosus. As long as we have something on the AUF, because we know the risk of that baby demising inside in utero is very low. And if it's now after 32 weeks, then that's when he was talking about the umbilical artery Doppler. If it's absent, then the decision to deliver should be immediate, within 24 to 48 hours. And Then you also mentioned about the issue about the perfusion and the diffusion, that if it's after 32 weeks, it has to do with diffusion. So we have to check the middle cerebral artery Doppler. And in the middle cerebral artery Doppler, if there is evidence of some brain sparing, which means the baby is at risk of becoming hypoxic. So the Dopplers are quite a vital instrument in determining the outcome.
Thank you, Mr. Zanga. As you know, this Dopplers and ultrasound, the sonographer are much better at it than us as obs and gynae specialists, and also as medical officers. So what are the things to look for when you are interpreting these Dopplers? What are the things which can actually affect your outcome or your results when you're doing a Doppler? I'm asking things like, issues with the gestational age, and issues with when, let's say, for example, there's abnormal fetal heart. Is there anything you consider when you're doing the Doppler? And what are those things which can actually give you a false result just because of the technical issues of it? Mr. Zanga?
Okay, so when we are doing the Dopplers, I think you mentioned quite a number of issues which have to do with technical considerations. And one of them has to do with the waveform which you are going to produce, which is as a result of, you talked about the angle of insonation, you talked about the beam should be parallel to the vessel which you are scanning. So if possibly you sample a vessel which is perpendicular, you will not actually get the waveform, or possibly if it's at a compromised angle, which is not less than 30 degrees, then you will find you have a waveform which will possibly give you some false results. Possibly to show that there's reversal of flow when there is none. So the knowledge and knowledge of setting the right parameters is quite important for you to get the correct results.
Thank you. Thank you. Dr. Dakala is still there?
Sorry, I was just speaking on the muted mic. Sorry, Dr. Verenga. There is a question for you, Dr. Verenga, from Dr. Madula. Dr. Madula is saying, Dr. Verenga, is the inverted Doppler wave a problem?
Not really. It's not a problem. There are two schools of thought. One of them says you should invert it and measure it. Like you see my Dopplers there. Others say don't invert it, just measure it the way it is. I know, especially in cardiology, fetal echocardiography, that the fetal echocardiography, the pediatric fetal echocardiography, normally they say don't reverse it. But us in obstetrics, we normally want to reverse our Dopplers and measure them the other way around. But it doesn't affect the actual value at the end of the day. It doesn't affect it. It's just more convenient, I think, to measure it inverted like this. I mean, looking upwards, looking positive, as my Dopplers, which I showed you.
Absolutely. So Dr. Sydney Farai, welcome, sir. How are you? Dr. Farai? All right. So while Dr. Farai is unmuting Dr. Verenga, there's another question from Anonymous. The Anonymous is saying, thanks so much for the presentation. That is so informative. What are the normal ranges for positive index?
There are no normal ranges. There are nomograms. Just like we said from the beginning that there is no arbitrary value to be used, you always have to check on the nomogram. The resistance at the level of the placenta is worse in early pregnancy. That means there is more resistance in early pregnancy, but it decreases towards term. And of course, for post-dates, it may go up due to placenta natural, placenta insufficiency, later on placenta insufficiency. But normally, the umbilical artery pulsatility index and receiving index drops towards term. But there is no absolute value which you say this is normal, this is abnormal. You always have to reference your value to the nomogram. This is very, very important. Most machines, modern machines, have nomogram for all these values. If you don't have them, you can go on the internet. Most websites will give you the nomograms and the authors of those nomograms, so that in a unit, you constantly use one of them where you can check physically if your machine doesn't have a nomogram. But most modern machines will come with a nomogram for all these Dopplers that we discussed here.
Thank you. There is Unkuwe Njunguna, and Njunguna is asking, how wide will be the gate of the Doppler? Dr. Verenga?
2 millimeters. 2 millimeters. 2
All
millimeters.
right. Okay. Zika is saying, why do we have to use the same? Why do we have to do the same management if there is reverse end diastolic flow and absent end diastolic flow for an uterine artery? Is there room to wait for at least 32 weeks for a patient with absent end diastolic flow?
Is it in the uterine artery or
uterine artery? Uterine artery Doppler.
Uterine artery Doppler is nothing to do with the delivery decision. It's more to do with diagnosing the cause of the small vaginal edge. So uterine artery is not involved at all in decision delivery. It's probably maybe they are referring to umbilical artery.
Oh, sorry, umbilical artery Doppler. It's my bad.
Yes.
It's actually my bad. Umbilical artery. Yes.
The decisions are based on the TRAFU study results. There's a study that compared the monitoring of small vaginal age babies which happened to occur before 32 weeks. They showed that it is better to deliver these babies if they have an absent or reverse end diastolic flow after 32 weeks than to wait after 32 weeks. But before 32 weeks, it has been shown that if you can do ductus venosus Doppler and you monitor that ductus venosus Doppler and wait until there's absent or reverse end diastolic flow, and then you deliver, the outcome of those babies is better compared to trying to deliver everyone very quickly, where the baby will suffer from early delivery, because every day gained by a baby who is being monitored increase the chances of survival by around 2% for each day gained by a baby who is abnormally small due to placenta insufficiency. So that is the reason. Absent and reverse, probably they are telling us the same thing, that there is a problem at that level. But if we can monitor the ductus venosus, then we monitor. But after 32 weeks, it has been shown that there's no benefit. Instead, we are exposing the baby to the risk of hypoxia. If you remember this chart here, with this chart, probably I also want to speak to another question which was asked by Dr. Ziki, my colleague. That what this chart tells us is that there is no single parameter that is very precise or very sensitive to fetal acidosis. So as a result, we need to use a number of parameters to make a decision whenever we want to deliver the baby. This is why when we have an absent or reverse end diastolic flow, we also want to employ the ductus venosus. If you are in a center that does CTG, you also need to employ the CTG so that you combine all these parameters, because with the combination of all these parameters, if they are abnormal, the likelihood of having a pH of less than 7.2 or less than 7.1, especially with the absent fetal movement and absent tone, is very high. But however, fetal Dopplers have a role in monitoring small for gestational age babies, as we show that there are studies that have been done that have shown that surveilling or monitoring small babies and delivering them at the right time will reduce the perinatal morbidity and mortality by a factor of 4 to 5. I think I've addressed most of the issues.
Yes, Dr. Verenga, last part. When would you admit a patient for steroids? Is it when the RI is raised, or when now you start having absent and diastolic flow? When would you say, okay, now I'm worried that this patient is going to be delivered early?
Thank you so much, Dr. Dakalo. I think this is answered by this graph here. So for babies who are probably we are talking of these babies here, because these ones after 37 weeks, there's no worries for antenatal steroid rate. So we are saying after 32 weeks, and you see that there's absent and diastolic flow, you need to deliver these babies for delivery, to administer for antenatal steroid and plan for delivery. However, for babies who are before 32 weeks, the moment we discover that there is now absent or reverse end diastolic flow, we can start them giving antenatal steroids while they are under a program of surveillance, waiting for the right time. Like I was saying, that prolonging delivery for each day, you may improve survival of this baby by 2%. So as a result, the moment you see that they are grossly abnormal Dopplers, antenatal steroids can be given, but it may not necessarily mean that the baby is due for delivery. But we are saying the decision to deliver can be made anytime. And for certain babies, when we make decision to delivery, we may decide that they be delivered within 12 hours or within 24 hours, where there is no time to give antenatal steroids.
So what you're saying is that for a baby at 32, let's say 31 weeks with decreased end diastolic flow, you don't normally give that patient a steroid, that baby mother a steroid.
Before 32 weeks, no, we don't. We monitor. If we now even absent, because like I showed you in this graph, that babies don't deteriorate as quick as most people think that they do. As I showed you in this graph, that look, we have time before the baby reaches a stage where we say the baby will die. So if a baby comes with absent end diastolic, with reduced end diastolic flow before 32 weeks, we can decide to monitor this baby every week. If in our center, we monitor every week. But if there's absent end diastolic flow, we monitor them every 3 days. But in this case, this is where we give antenatal steroids for babies below 32 weeks, because we know that we still have time with this baby. But a baby who is already absent in diastolic, this baby will give them antenatal steroids in advance, because we know we can make a quick decision to say, look, things have deteriorated here. There is even bradycardia on the baby's heart, or now the baby is starting to have ascites, and there's now reverse or absent end diastolic flow in the absent A wave, reverse A wave, deliver in the next 12 hours. So these are the babies we will give antenatal steroids. But absent or high PI at 29 weeks, we normally don't say give antenatal steroids, because you know that this baby may take us for another week or 2 weeks actually of surveillance, or even more. We have monitored babies from as early as 26 weeks, and we've gone all the way to 32 weeks.
Yeah, Dr. Matsimela was also elaborating on Dr. Zike's question. Yes. He said, I was under the impression that the absent end diastolic flow is not an indication for delivery, but reverse end diastolic flow is. Your comment, Dr. Verenga?
It depends on the gestational age, guys. It depends on the gestational age, right? Absent end diastolic flow, even the reverse end diastolic flow, is not an indication for delivery for a baby who is below 32 weeks. But Dr. Venosa's Doppler is the one we use to determine delivery. But after 32 weeks, from other studies, such as the GRIT study that we also done for these babies who are now big baby beyond 32 weeks, it has been shown that if there is absent or reverse end-diastolic, it's better you take out the baby for this kind of babies. You will reduce the risk of fetal hypoxia or acidosis after 32 weeks. But before 32 weeks, you may actually cause harm in taking out a baby whose ductus venosus Doppler is still normal, but there is absent or reverse end-diastolic flow by taking them out too early. Remember my first statement that the goal is not to take out the baby. The goal is to take out babies at the right time, to make sure that babies don't come out too early or come out too late. Because both extremes are not good for babies. Taking them out too early is not good. Taking them out too late is not good. So again, it's not arbitrary. It's not arbitrary. The arbitrary statements don't work. Everything has to be put in context.
Yeah, we get you. So, thank you so much. Because of we're running out of time. Just last question, Dr. Verenga, the uterine artery Doppler. What gestational age do we do it? At what range?
All right. So the uterine artery Doppler has many uses, clinical applications, which I mentioned from the beginning. So at 11 to 13 weeks, we do the uterine artery Doppler. The reason why we are doing it is to screen for preeclampsia and babies who are likely to have fetal growth restriction. That is 11 to 13 weeks scan. Then in mid-gestation, between 19 to 23 weeks plus 6 days, we do the uterine artery again to screen for preeclampsia. I think those who are aware of the latest FIGO recommendation and also the results that came out from this pre-study, which was done by Fetal Medicine Foundation and also the ASPRE trial, we know that there is a role of using the uterine artery to screen for preeclampsia and fetal growth restriction in first trimester. And we know from this pre-study that there is a role for using the uterine artery Doppler to predict women who are going to develop both early and late onset preeclampsia. So we do uterine arteries here. Then when it comes to third trimester, the role of the uterine arteries will come in interrogating the cause of the smallness. We are trying to answer the question of saying, why is the baby small? In a placenta which is poorly perfused, a poorly perfused placenta is going to give us an abnormal uterine artery Doppler. An abnormal uterine Doppler is, in other words, is telling us that, look, this baby, you are asking why is it small? It's small because its placenta is not 100%. It's not functioning the way it should. The placenta is failing already. This is what the uterine artery Doppler is doing. So in clinical application, you only do uterine artery Doppler besides the screening for preeclampsia. You do uterine artery Doppler in trying to interrogate an abnormally, a small for gestational age baby. But for a normally growing baby, there is no room for clinical application of a uterine artery Doppler. But those who work with us in fetal medicine, you see that we do it on every patient because we're a training center and we're also a research center, and we want our practitioners to be super good at doing uterine artery Doppler. So they do it on everyone, irrespective of their risk profile. But clinical application is what I've just described.
This is the last one, I promise. From Innocent Duna, because it's related to what you're saying. How about when there's absent or reverse end-diastolic flow before 32 weeks with a patient with preeclampsia, in a way where you know that they might be, the intrauterine growth restriction might be related to preeclampsia? If you know that, does it make a difference in making a decision when to deliver?
Yes, it does. It does. Remember, preeclampsia is a disease that affects both the mother and the baby to different extent. Preeclampsia may affect the mother it's a multi-organ disease. And one of the organs that preeclampsia attacks is the placenta. Right. So of late, I think it is now acknowledged, one of the reasons why we have moved from imminent eclampsia into severe preeclampsia, that we have recognized that preeclampsia as a disease entity affects different systems to different severity in each individual patient. Not all patients are affected to the same degree in each system. Some women are affected their renal system more than others. Some are affected the central nervous system and they end up fitting and having eclampsia. Some are affected the liver and they have liver injury. Some are affected the placenta worse than they are affected in other systems. So because of that, we assess the baby in preeclampsia to see the extent to which the preeclampsia is affecting the baby. Because the decision to delivery can be due to the maternal affection or the fetal affection. If one of the systems of the mother is affected so much so that we think the mother will not be able to recover successfully, will suffer the sequel of the disease, we may order delivery of the baby irrespective of the fetal condition. But however, if we have a situation whereby the mother is stable, but the fetus is now affected to the extent that we need the baby to come out, otherwise the baby will die inside, in that case, we are going to recommend delivery of the baby irrespective of the maternal condition. I don't know if that is making sense. So
yeah, it does.
Preeclampsia disease requires that we balance the system which is affected the most in making the decision to delivery. And the systems are not affected to the same degree in each individual women. I don't know if that is very clear, because the old teaching used to think that preeclampsia always has to cause fits. It may not cause fits, but it may totally destroy the placenta. It may not cause fits, but it may totally destroy the woman's kidney or destroy the woman's liver. So because of that, all systems have to be assessed and decision based on that.
Dr. Verenga, thank you so much. We had to expand it because this topic is a very popular one and people want to know about how to manage this kind of issues in with Doppler. So yes. Thank you again. We are so happy to have you back. I see you're still safe, and thank you to the panelists who are here. And I have been asking for the people who need a CPT points. I only received 3 emails for people who need CPT points. If you still need CPT points, please send the request to me as a form of email, and then we'll send you the certificate. So, Dr. Verenga, we'll see each other next week. Bye-bye.
Thank you so much, Dr. Agalo. Bye-bye. Bye-bye, everyone.
Bye.